Hey everyone, and welcome to the Coast to Coast Plastic Surgery Podcast. I'm your host, Dr. Caleb Steffen. Each episode, I sit down with leading plastic surgeons from across the country to explore surgical technique, clinical decision-making, and the artistry behind aesthetic and reconstructive surgery. Whether we're discussing complex cases, innovative approaches, or the philosophies that shape great surgeons, our goal is to elevate the conversation and help advance our specialty. Hey everybody, thanks for joining us. This is Caleb Steffen with Coast to Coast Plastic Surgery, and here with my very good friend, Dr. Phillips from the Houston area. Is that right? So board certified?
Well, originally Houston area. Yeah, originally Houston area. Moved around for my training, and then finally my wife and I, we've settled in San Antonio, Texas. We've been there for about a year and a half now.
Cool. And how are you liking it?
It's great, man. The opportunity here is nice. The city's nice. It's got that kind of the big city feel with not a lot of the big city problems. So we've really found a little home here. So it's good.
Oh, cool. That's great. So what's the river walk like this time of year? A little chilly yet?
No, I mean, well, today it's like 75 degrees outside. I mean, it's a beautiful day today. A little bit wind, but not bad. I mean, the winter here in Texas lasts for about a week and a half, 2 weeks, and then that's it. So
very good. And currently you mentioned wife and kids. How many kids you have?
yeah, two kids. We have two daughters, a 10-year-old and a 12-year-old. So the 12-year-old will actually be 13 in about 2.5 weeks.
So going to have a teenager, huh?
Getting ready for the teenage years. Yeah.
You pretty excited about that?
Yes and no. Yes, that, she's getting older. No, that she's getting older.
Yeah. I mean, the little years go by too fast, and then who knows everybody the way they act about like teenagers. I've got one myself, about to have another one, I guess, next year. So there'll be two teenagers in the house, and that'll be something. But so far, so good, I guess.
Yeah, just manage the hormones and manage the crazy schedules that we have. So
I feel like a glorified taxi cab driver, right?
A lot of times, yes. Both of my girls are in competitive dance, so they're dancing for anywhere from 2 to 4.5 hours, 6 days a week. So
wow, that is a lot.
Yeah, and of course, they're at least they're at the same place, but their classes never start at the same time. So, like either my wife or I will run one, drop them off. The other one will stay home and do homework, and then take the other daughter, and then we'll arrange pickups. And it's a lot of back and forth. But luckily, we only live about 10 minutes away from the dance studio, so it's not like we're trekking across town.
Okay, and they're getting used to their new dance coaches and all that kind of stuff.
Oh yeah. They've made great friends. There's girls spending the night over at our house. We usually get one on Friday and then return them to their parents on Sunday. So
sounds like fun.
I say I don't have two kids. I have somewhere between 3.5 to 6 kids at any given moment. So that's good.
Cool. Well, how did I don't think I've ever heard this story. How did you and your wife meet?
Oh, so we've been together since we were in college.
Okay.
I took a job between my junior and senior year of college. I wanted a job. I knew I was going to go to medical school. I took a job during the summer that I didn't want to have to think. So I was in the service department at the cashier of a car dealership for maintenance. You come in and get an oil change. I'm the guy that checked you out. I was the cashier. Well, her brother was a mechanic there, and her summer job was also a cashier at the service department.
Okay.
So we, started dating to the tail end of that summer. I kind of wasted a couple months, getting my courage up, and then finally broke the barrier, and then we started dating toward the end of that summer, and that was, let's see, 2003. So we've been together ever since then.
Cool.
Yeah.
That's pretty neat. I had not heard how that worked before.
Yeah.
So you mentioned dance and things like that. Anything interesting else that you feel like the kids are in or having fun with
Man,
this time of year?
the dance just absorbs so much time.
Okay.
Like we're traveling about once a month. Luckily, we don't have to travel too far. to
Okay.
dance competition. So we go to, Dallas, Austin, Houston, several here in San Antonio, but that's usually about once a month. And then so that basically eats up the majority of our free time,
Sure.
but
So
it's
by the
good.
so aside from being a busy plastic surgeon and taxi service to dance all the time, is there any Paul time left over?
What time there is? There's a little bit here and there. Sometimes I kind of try to mix in some free time of my own. I enjoy playing poker. So they don't have casinos here, but they have card houses. So it's
Hard house.
it's poker. Just kind of standard. Kind of just detract from the world a little bit and
Uh-huh.
kind of
So like Texas Hold'em, blackjack,
exactly.
craps, what do
Yeah,
you like to all
yeah.
the above?
Just no, just Texas Hold'em. Yeah.
Okay. Cool.
Yeah.
What's the best hand you have ever had in kind of play ever, I guess?
Yeah,
You
so
hit that royal
it's
flush,
funny.
or
I have hit a royal flush before, and
did you hit it when someone else also had a good hand? That's the key, right? Is you got to have
man,
someone
I
who
don't
has a
even
good,
remember. I don't
yeah.
remember that part of it. But it was funny. The day I hit my royal flush, uh, maybe 45 minutes later, I also hit a straight flush,
Oh
and
wow.
it was in a hand. And I remember this. It was me and my parents were, visiting some of their friends in Dallas. So we go up to Oklahoma to the casino there because just something to do. I didn't have any money. I wasn't prepared to go play. So my dad's like, "Well, here's a couple $100. Let's play." All right, fine. So in the hand, it's myself, an, another person, and my dad in the same hand. Well, if you're familiar with poker, you have the flop, the first three
Yeah.
community cards, then the turn, which is the fourth community card. Well, I hit the straight flush on the turn,
Okay.
and I the first person to their turn was the second, the outsider, let's say. Well, he was thinking about what to do, and my dad out of turn goes all in. So the outsider, he passes to my dad, and because my dad acted out of turn, the action stands, so he's all in. Well, I've got the straight flush. I can't be beat. So I'm like, man, this is his money like that I'm playing with, but I can't like fold. I can't just concede. So I call, and then the last guy folds, and my dad goes, "I have the ace high flush," and I'm like, "I have the straight flush." So I kind of, I took his money, unfortunately, that hand, but I gave it back to him. After we were all said and done, I gave it back to him. But so that's
Fair's
what I
fair,
remember
right?
out of that. Yeah, that's what I remember out of that hand. That was fun.
If only he hadn't gone so soon, the other guy would have been in too, maybe.
Maybe. I don't know. I don't
Only
know. We'll see.
no one knows, I guess.
No one knows. Yeah, right.
Haha, that's pretty good. So, have you been following? Were you happy with the Super Bowl where Chiefs got smoked by the
Man,
Eagles? I think I
I
saw
haven't
that
paid
text thread.
any.
Everybody else seemed happy about it except for me, right?
Yeah, yeah, you were the only one who like, man, but you can't win them all. I haven't really paid attention to professional football since I graduated high school. When I graduated high school, I think the Oilers were still in Houston, or they had just moved to Tennessee. So at the time, we didn't have a professional football team in Houston. Then I went off to college in California, didn't really care, and had really never gotten back into professional football. I like University of Texas, so I follow a
I
lot of
see that
college
from your
football.
hat.
Yeah, yeah, yeah. You can usually find me wearing a Texas hat of some shade or color. So
Yeah, they did all right this year, didn't they?
yeah, they did all right. They came up a little bit short, but it's always a process. It's just continue. Hopefully they can get better. They have Arch Manning coming in this year as their quarterback, so it'll be interesting to see how that goes down.
Now, whose son is that again?
He is, well, let me get this right. He's not Peyton or Eli Manning's son. He's the third brother.
Boy, that guy
Cooper,
would really like hearing this, wouldn't it?
I think his name is Cooper Manning. And
Okay.
people say that he was the best athlete of the three brothers. But, with injuries or whatever, he didn't he wasn't a successful professional. I don't even know if he ever played professional football, but yeah, I think it's Cooper Manning. I think that's his dad.
Okay. Well, we'll see what
Yeah.
happens with that, huh?
Yeah, it'll be fun.
Okay.
Regardless, who knows?
Okay. Well, it's quite a process, which we'll talk a little bit about to be a plastic surgeon. If you weren't a plastic surgeon, what would you be? Still be a mechanic or something, or
Ah, man,
what would you
you
do?
know, it's so foreign to me. I wanted to be a surgeon of some sort since I was in middle school, right? So I got into it. I broke some bones, growing up. So I was in the orthopedics office about once a year, it seemed like. And
Hmm.
I always thought I was going to go to orthopedic surgery. And then did med school, fell in love with plastic surgery, so became a plastic surgeon. So to ask me what I would do if I wasn't a plastic surgeon, I like math. I like numbers. I can like visualize numbers in my head really easily. So I'd
Yeah.
probably be doing something with math or engineering, something like that.
Hmm. Yeah. That's cool. How common do you feel like that is, that story? Because, I wanted to be a doctor of some kind since I was very little. You feel like you hear that pretty commonly for
You know,
doctors and surgeons, What do you
you,
think?
you know, I think as a surgeon, like you have to kind of plan ahead, right? So, in college, you have to take your pre-med classes. So the plan for a lot of people, they have to start, in high school. Okay, well, what grades do I have to get to go to a good college so I can get into medical school? So
Hmm.
I think that the foundation is laid well before med school and, the doctor world. Everybody growing up, they want to be, a fireman, a policeman, a superhero, or, an actor, an actress. But a lot of those dreams, they get pushed aside for whatever reason. But, plastics or, not plastics, but medicine, it's something that you can always work toward. Like it's rarely ever taken away from you if you work hard enough, dedicate yourself to the life.
Yeah. So is that like advice you'd give for people, young people thinking about it, that what would you, I mean, based on your story and kind of your thoughts, what would you say to them?
Find something that makes you happy.
Yeah.
If you like digging ditches, go be the best ditch digger there can be. If you want
Yeah.
to, help people or be something in the medical field. It's not always a doctor. I mean, you can be a nurse, you can be a psychologist. There's so many avenues to help people. Just go out there, find some experience. You learn best through experience. So, go volunteer at some place. Go, you know, follow somebody around, go do something. I mean, your network of friends and family is wide enough. You can get so many experiences that, just find something that you really have a passion for. Because there's going to
Yeah.
be days where you don't want to go to work. But if you enjoy what
Mm.
you're doing, it makes it a whole lot easier to get up and go.
All right, Dr. Phillips. Well, tell us a little bit about your practice. You and I have a lot of history together of being at University of Tennessee together and training and all that. But and we text, pretty regularly yet.
hmm
But what's going on with your practice?
All right. So when I finished residency, I took a job in New Mexico. I was working for a hospital. I was there for a little bit over a year, and that was probably a big mistake on my part. As a resident, I wasn't ready to start a practice. I wasn't ready to, from the ground up, from hiring the front desk. And not only is, I'm starting it, I'm also under the guise of a hospital. So you have all their, regulations, right? And so it was very difficult for me to do that. So after about a year, I switched jobs to private practice in El Paso. I joined another plastic surgeon there, and it was only cosmetic. So just, face, breast, body. And I was there for about 6 years. My wife and I have said, we were going to live in New Mexico / El Paso for 3 years. Well, that turned into 7 years.
Uh-huh.
And then I was like, the kids are getting older. Let's go back home to Texas. So I found a spot in San Antonio. And so now I've been here for about a year and a half. There's three other surgeons here in the group. It's still only cosmetic, so we don't deal with insurance. It's all and we do everything from top of the head to ankles, essentially. So it's a good group of guys here. The office staff is great. We have two surgery centers, one in our office building, and then one directly across the street. So together we have six operating rooms. We have the ability to keep patients overnight if we need to. We have an overnight nurse that comes in and is with the patient overnight. And, it's really self-contained. I'm going to knock on wood here. So I haven't been to the hospital in a year and a half, which is amazing. So it's so convenient. It's a pretty well-oiled machine. The senior surgeon here has been in practice for, I think, 16, 17 years. So he's got it, and he's a good business mind. So he's got everything pretty well organized. And then, I slotted in a year and a half ago and, really never missed a beat. So it was good.
That's that's nice. So I want to kind of take it back to that transition because obviously there were some factors that made you decide to take the practice in New Mexico when you were looking. So what's the high point of that and that first year out where, you decided it was a
Yeah.
mistake? What's the best part of that experience and what kind of drew you into it? And then what wound up being kind of the worst of that? Because some people who are watching this are going to be either thinking, maybe they want to be the next Dr. Phillips and work their way through this, or they just want to understand, hey, what does it take to be a plastic surgeon, or how does that work? So for that, let's kind of walk through each of those steps. What was kind of the highs and lows of that New Mexico practice, and what was it really that made you settle on that in the first place? Was it money? Was it location? Was it the promise of the job? What were those? What was going through your mind on that first thing, and what was it like?
So, yeah, that's kind of multifold. One is it was exciting to say, man, I get to start a practice. I get to create something that this hospital has not had in the last 8 years, and I can cultivate it to my own. That was my dream, right?
Okay.
Didn't realize that there is so many other factors because you're dealing with a hospital that you have to you have to pick your battles essentially. Um, the hospital there was in desperate need of a surgeon. So their offer to me was twice as much as any other place that I interviewed. So for salary wise, it was, there was no question. It was, like I said, I had interviewed probably four or five other different places, but it was twice, the salary that they were going to give me, guaranteed salary, was twice as much as anybody else. So, discuss it with the wife, and it's like, hey, let's go out there. It's a 3-year contract. It'll allow us to pay off all of our medical, all of our student loans for the both of us. Go out there for 3 years and do it. Perfect. All right. Once you get out there, it's great because it's like a glorified fellowship. Like you are the surgeon. There's no other surgeon around for 60 miles. Um, so, you get everything from hand surgery to breast surgery to dermatological, reconstruction surgery. So, a lot of doctors coming out of residency, they're worried that they're not going to get their numbers for the first year, year and a half to take their board exam. But I had all mine done in the first, 4 or 5 months. So that stress was gone as far as, qualifying for the boards. But at the same time, because you are so busy, you lack the opportunity to get home and study for the written part of the exam. So, all in all, it was a good adventure. I think it shaped, me. It let me see the business side of it too. That's something you're not really exposed to as a resident.
Yes, well, that's difficult. And for the watcher and listener, to become a board certified plastic surgeon, two parts: written exam, where you take the test where they prove that you know everything there is to know about plastic surgery, which is a lot because the stack of books, you can see one of them back there, which is an older one, a McCarthy set. I've got other sets than that, but they're like this wide in terms of if you take all 8 volumes or whatever. So you have to know everything there is to know about that, and then followed by an oral exam where they test you on your surgeries and imaginary surgeries and say, can you actually take care of a patient in a real situation? So it is quite a rigorous process that requires time, right? Requires time to sit
Right.
down and study, and being busy in practice, isn't that? So in terms of, do you have regret? Do you wish you hadn't done it that way, or was it such a valuable experience? It wasn't for you for the ultimate practice, but was it the right choice for the right reasons at the right time? Or you're like, if I had it to do over, I would have skipped that step and gone to one of those others that maybe had the lower price tag, but where I would have had maybe more time to ease into practice or things like that. What's your take on that in hindsight, the retrospectoscope?
You know, I think about that. It's like at the time I wasn't ready and didn't understand the nuances of, the business side of it. And I don't enjoy the business side of it. I want to
Okay.
do the surgery, I want to do the patient care, you know, and mentally I wasn't ready to do all those decisions, to do the negotiations with the breast implant companies. So, so right out of the box, I was like forced to do all this. And I have no foundation of what is normal, what's a normal practice run, what is a normal how does a normal practice do consignment, do they do a skincare line, do they not do a skincare line, do they do a med spa, do they do injectables, do they focus on one thing or not? So I was just trying to catch everything, and it was pretty overwhelming, but it gave me an insight into what it takes to run a plastic surgery business. And
Mm-hmm.
then I stepped completely away from it. I went, 180 degrees when I changed practices. I was, essentially a resident again, just operating, taking care of patients, operating, taking care of patients. And that's what I found I truly enjoy doing. I don't want to do the business side of it. People ask me, hey, are you ever going to go out on your own? I'm like, man, I've been there before. Do I want to do that? But, at some point I might. Um, at some point I might take over the business here. I don't know. That's still way down the road for me, I think. It might be sooner than later, but having that initial experience, it will lead me to say, hey, are you ready to do this? And sometimes you just got to rip the band-aid off and do it. But
Yeah.
but if you ask me right now, today, would you do it again? Sure, I would.
Yeah.
But I would structure things differently. I would
Yeah.
say, okay, instead of doing hand, breast, body, cosmetic, uh, dermatology, yada yada yada, it would be more organized. It may be
Sure.
hand one day, cosmetic one day, breast one day. It's
Mm-hmm.
not okay. In the morning, you're going to see three hand patients. You're going to see two breast patients. In the afternoon, you're going to see four skin consults, and then you're going to do a cosmetic consult. It's like, man, it's just like you're wearing so many hats at one time. Yeah, it can
Right.
be fun, but it's a little chaotic sometimes.
Mm-hmm. Yeah, well, that's interesting. So, for the listener who is not a plastic surgeon, some of the things that Dr. Phillips was listing off there are some of the different pillars of plastic surgery, right? We're talking about these 8 volume texts and things like that. And for historical reasons and for the principles of plastic surgery, that's why plastic surgeons do hand surgery and they do delicate dermatologic surgery on the face, and of course the breast surgery, the reconstruction, the cosmetic surgery, it all fits together, but you kind of have to dig a little bit because it may not seem that way on the surface. So as far as the second place, moving on, for the practice was how you wanted it more or less and doing what you wanted to do. So was
Right.
it location? What said it's finally time to pick up and go to San Antonio?
Pretty much location.
Yeah.
My wife, she grew up halfway between San Antonio and Houston. I grew up in
Mm-hmm.
I grew up in Houston. So it was like it was always our thought that we're going to end up back in Texas.
Yes.
So this practice had an opening. He's been in business, like I said, 16, 17 years, and it was doing exactly what I had been doing for the last 6 years in El Paso. So
So it's just
it
turnkey,
was,
walk in and
yeah,
keep rolling.
yeah. I mean, I actually, for the first 3 or 4 months that I was quote unquote working here, I was working in El Paso at my practice there Monday through Thursday. I'd fly out Thursday night, see patients here on Friday, maybe operate on Saturday, and then fly back and work on Monday.
That's a
So
busy schedule.
yeah, I mean, like, it was under the radar, like no one knew what was really going on, but I didn't want to. leave El Paso, have no patients here in San Antonio,
Yeah.
and then because we get paid for when we work, right? Like
Right.
we don't punch a time clock, so it's not a salary position.
Right.
It's eat what you kill. So if you're not killing anything, you're not eating. Well, like I said earlier, I've got a wife, two kids to support, so can't really go with no food on the table.
Yeah, that's right. The classic jungle metaphor for medical practice, which is kind of funny when
Right.
you think about it, that how often
Yeah.
that comes up as the eat what you kill means
Right.
you take in that you do the consults and surgeries of people you see. That makes so much sense.
Right.
So, well, take us. So now we know kind of where you're at in the San Antonio area. So, what's the typical work week like for Dr. Phillips? Take us through. I mean, are you a Sunday to Sunday guy? Are you Monday to Saturday, Monday through Friday? What's the breakdown of, a lot of people watching or listening may not even know, the differences between clinic days or surgery days. What's your work week like?
So, it's a luxury that we have that not a lot of surgeons have. We own two surgery centers. So, like I said, we have six operating rooms. So I can operate 7 days a week if I wanted to, but you have to have staff for that. So are
Right.
you really going to take away your staff's family time just because I want to operate on Sunday morning?
Hmm.
So there's give and take there. So, but I could operate 7 days a week if I wanted to. I don't want to. I want to have some family time too.
Right.
So typically it's Monday through Friday. Wake up about 5 o'clock in the morning, do kind of some daily reading, some for personal edification, not for plastic surgery world. Um, get to the clinic about 6:15, 6:30. If I have a surgery that day, operate from 7, and then until, the cases run out. So some days it'll be 11:30 we're done in the morning. Some days it'll be 4 in the afternoon that we're done. And because we're so close to our office, either ORs are either downstairs in this building or directly across the street in a building. We walk across the street back and forth. We walk upstairs to see patients in between surgeries. So, it's really good. And then usually I can usually be out of here by 3:30, 4 o'clock. About the time the girls get home, we knock out some homework, and then we start the dance. 9 o'clock at night, dance wraps up. Get the girls to bed, and then go to sleep. Repeat the process the next day, Monday through Friday.
Sounds like a full week for sure, and you're right in the
It,
thick of it with the
it
kids,
can be.
right on top of you. You can't, you kind of take your hat off for a little bit during the day, but I know there's
Right,
texts and calls about what's coming up in the evening and things that you got to take care of as well. So,
right. Yep, yep.
some people may want to know who are the other players, in your and the work end of your life. We've talked about family a little bit, but what sorts of people are involved in what sorts of people are involved in your work week? Who are the people are familiar with nurses? I mean, what other sorts of jobs and people do you get to work with all the time?
Right. So on staff, we have two anesthesiologists on staff. We have a contract with an outside anesthesiologist group. So, like I said, if we're running 6 rooms between the 4 surgeons, and we also have outside surgeons that operate at our surgery center. So, anesthesiologists. There's, nurses in the operating room. There's circulating nurses. There's first assists, instrument techs, operating room techs. So those are all, OR support staff. In the office here, let me just kind of walk through the front door. So we have a valet outside because parking's not very good. So we have a valet. As you walk in,
That sounds fancy. I need to get one of those.
it's not fancy. It's just a really small parking lot. So rather than make the patient walk across the street from the parking lot to us, we have the
It sounds
valet.
fancy.
Uh,
Sounds fancy to me here in
hey,
Central Missouri. I like it.
we have a red carpet going in the front door too. So you're getting the Hollywood experience here.
You would. That's good.
Um, all right. So you walk through the front door. Receptionist is there to greet you, get you checked in, get you the necessary paperwork. Then you come upstairs. We have three patient relation coordinators. So they walk you through the surgeries. They sometimes, patients, if one of the surgeons is in the operating room and you have a consult that day, they'll see the consults for us. They've been here for at least 4 years, I believe. So a lot of times the patient's like, nope, I've seen his work on Instagram, TikTok, whatever. My friend had surgery with him. So they'll do the consult for us, which is amazing. And then when they come in for their pre-op appointment, obviously I'll meet them, and then answer any questions they may have. We have a sales team of one, two, three, four individuals. So if you call the office, and you discuss the surgery, you can actually pay for your surgery and book your surgery before seeing anybody. You can just do it on the phone. Uh, we have a CFO, Chief Financial Officer here. She does all of our accounting, all of that. Um, I think that pretty much covers everybody in the office.
That's
So,
cool. It's interesting. In the old days, a plastic surgeon, and any surgeon for that matter, any doctor, their reputation was either based on community or other doctors in the community. And that's about all you had to go off of. Maybe a little bit of
right,
word of mouth from someone who had something. But now social media and other things have changed that. People can see before and afters. Maybe you came to the office and looked at a book with those sorts of things
right,
beforehand.
yeah.
But now people can really visually sample the wares before they ever meet you. So tell me what is your life like in terms of how do you manage as a plastic surgeon yourself? What is your involvement in social media and that, or how
Oh,
do you stay engaged with it versus having people that you've hired? How does that work for Dr. Phillips?
yeah. So I apologize. I forgot we have two social media people on our team.
Hey, no
So
offense, guys, if you're watching, we
yeah,
didn't
I
mean
know.
it. We didn't
I'm
mean it.
sorry, I completely forgot. I was just walking through. But no, wait. So we have
No, you
two
queued you
full-time.
queued me up so we could really talk about him real nice.
Well, I know. I mean, I didn't want to, tip my hand, but
Right, right, right.
uh, no, social media, man, it's one of those, to me, it's a necessary evil, right? I mean, granted, I sit there and, I waste so much time flipping through Instagram and TikTok with reels and jokes and, dumb stuff, right? But it's necessary. If the marketing is necessary, that's where people are finding surgeons. That's where people are learning about plastic surgery. Um, so, every few days, the social media team is on me for, hey, let's record a video. Not right now, not right now. I try to push it off because I don't like being in front of the camera, right? I
Right.
just want to keep my head down, work, and that's how I want my reputation to be. I don't want to be,
That's
oh,
it.
you're some TikTok, Instagram celebrity, right? I don't want to be known as, Dr. Pimple Popper because she became Instagram famous, right? I want to become well known because of the results that I perform. But I know it's necessary, right? I know the
Yeah.
marketing has to be there. Um, so, begrudgingly, I do the videos. Begrudgingly, and I try to make them funny because, anybody can sit here and talk like this on something, but that's not engaging. That's not entertaining. Nobody's going to really sit there and watch it because they're going to watch it, but they're going to ask the exact same questions when they come in for consultation. So it's like, let's make it funny. Let's, drop some pearls of knowledge every once in a while. But, that's my social media take on it, I guess.
Cool. It's a shame someone so good looking doesn't want to be an Instagram star. That's too bad.
Caleb, what do you want?
That is
What do you
that
want? You're
is too
buttering me up. What do you want? What do you
no,
want?
nothing. Nothing. I'm just thankful that you're doing this. All right. Anything else about your practice?
Well, the one thing, kind of flicking back to social media, uh, people ask on there, they bring in their dream pictures, right? And this is what I have to tell people. What do you post on the internet? You post your best case scenarios, right? You post your best results. And then what do other people post? Well, they post the botched results, right? So you have these opposite ends of the spectrum. And it's going to be, probably 1 to 2% of all the results are those best case scenarios. So you have this entire area in between, which are, the majority of the results. It's a bell curve, right? Yeah, everybody's hoping to get this perfect outcome, right? And minimize the bad stuff because it's surgery, it's complications. Sometimes things go wrong. But you try to push it towards this side of the bar. And people need to be very careful what they read on the internet. because a patient that may feel they had a bad outcome is actually, on this side. If the surgeon says, hey, what we started with, what we get, it's over here, like expectation wise. But a person, a patient can go online and just absolutely blast a a practice because of whatever they had a bad experience. Maybe they woke up on the wrong side of the bed. Maybe whoever they were working with, coordinator, sales, nurse at the front desk, whatever. Maybe they woke up on the wrong side of the bed, and maybe they just had a clash that one day. Um, so patients can go and blast a practice, but how many times do you see a practice go back and defend themselves? You don't. Like
You don't see it.
I have never gone online and said, that's not the case. This is, here's your before and afters. Like, we can't do that. So it's
Right.
always one-sided. So, you
True.
have to
True.
kind of take things sometimes with a grain of salt. But not to say that some people just have bad technical skills. Some people just aren't careful in how they manage a patient. Things happen, people make mistakes. I understand that. But we aren't in this business if we didn't truly care about outcomes in people. So, like, people ask, what's the best part of being a plastic surgeon? The biggest compliment that someone's ever given me was, "Hey, doc, you've changed my life." Well, how, man? I just did a tummy tuck, right? Like, how did I change your life? And she goes, like, I just wasn't feeling good about myself. You restored my confidence. I feel sexy now when I wear my dresses, and so that's like heartwarming when you hear those stories, right? I mean, and I'm looking and I'm going, man, I could have done this better. Or, I didn't post you on Instagram because I don't like the way that this little area looks a little bit. Like, I'm my biggest critic. So when a patient, you know, gives you that compliment, even though you may, in your mind says, man, that's not perfect, they absolutely love it. And that's awesome.
Yeah. No, that's
So
very rewarding to have that life-changing experience for
yeah.
someone. It's something that's permanent. And, I always hope when someone's given you that compliment or you hear something like that, you're like, I hope you are now spending less time worrying about how you look and more time
Yes.
just living, you
Yeah,
know?
enjoy it, man. Like, our time on this earth is limited, right? It may be, 70 years, it may be 90 years. No one knows. Um, so just enjoy the moment, have fun, take your blessings, remember your blessings, count your blessings, be grateful for what you have, because what you may have, somebody else may not have,
True.
the I was talking to a worker here today, and she was like, man, I'm having such a bad hair day. I'm like, be grateful you have hair, man. Like,
You could be, you could
I'm
be, she
about
could be me. She could
I
be
know
me.
I'm about to talk to somebody that hadn't had hair since I've known them. So, but no, so it's like, man, just remember, there's always somebody that, man, they wish they had hair. Maybe they're going through chemo that, they lost their hair. Be grateful you still have hair. You know, um, man, I had car trouble this morning. Be grateful you have a car, right? Like,
Right.
there's always something to be grateful for. And I think a lot of times people just get too busy. They don't realize what they have. And
Hmm.
yeah.
That's
So
cool. Well, it sounds like for you, your practice is one of those blessings.
oh yeah. I mean,
So
I go ahead.
Well, I was just going to say, so you've kind of have it tailored. You've been able to zone in on what you like to do. So I was just curious, like, what is it now that you like to do? What is your week? Maybe not what's the favorite surgery, but on an average week, what sorts of surgeries are you doing most of the time?
So I primarily just concentrate on breast and body.
Yeah,
So breast augmentations. I think I went to a lecture one time, or it was a plastic surgery conference, something, and he was like, "Man, everybody loves these patients when they come in, and they show a young 20-something-year-old female that's this big around and has nice breasts to begin with, and the breast augmentation is a layup." Man, those would be great. That's not what practice is filled with, right? So yeah,
Right.
you might get some of those every once in a while. But the but the majority of it's not that, right? The majority of it is your average person who, they've had children, so they typically need a breast lift with or without implants. They need a tummy tuck. And so that's mainly what we do. We do a lot of BBLs. We do a lot of tummy tucks or abdominoplasties. We do a lot of breast lifts with implant. We do a lot of breast augmentations. We do facelifts. We do rhinoplasties. But I'd say, let's say on the average week between the four of us, 3, 12, we're operating, 18 to 20 times a week between the four of us. I'd say probably, let's say 20 times, right? So I'd say probably 16 of those is, a tummy tuck and or breast augmentation and or a BBL. The other four of those may just be a breast augmentation or a facelift or a rhinoplasty.
Hmm.
So, the majority of it is your typical mommy makeover.
Mommy makeover. Yeah.
Right.
Yeah, absolutely. Cool. Um, so some in some practices, group practices, I think you may have mentioned this earlier, but so do you guys work together? Do you tag team surgeries ever, or is it pretty much just kind of solo, you do it, and then another guy's in the other room next to you doing that, or how do you guys kind of divvy that up?
It depends. Some of the surgeons, they want to work alone. Perfect. I get bored if I'm just sitting around, right? So I'll jump into the other surgeon's case, and maybe I'll do the Renuvion for him or the Vaser energy for the liposuction.
Uh-huh.
Just things to keep moving along, to keep me busy. Um, and it's good for the patients. If
Right. Less OR
there's
time, right?
Yeah, exactly. Less OR time, less time under anesthesia. And the staff likes it too because they get out of here faster, right?
Right.
So, and when I'm helping him, I'm not, doing the surgery. He's still making the pocket for the implants. And then he moves to the other side and does the pocket over there, puts the implants in. And, but I can help sew up. So that eliminates time
Hmm.
for suturing time. Suturing time is one of the biggest things in plastic surgery. I mean,
Yeah.
we have these long incisions. We're not using staples like general surgeons are on the skin.
True.
We're
True.
making it look pretty because patients are always asking, "What's the scar going to look like? What's the scar going to look
Right.
like?" So if you have two surgeons working together, it basically cuts the suturing time in half. So
Yeah.
so yeah,
Awesome.
so yeah, we do work together on the longer cases just to keep the patient safety, uh, patient and get them off the operating table quicker.
Cool. Well, you mentioned the best compliment that you've gotten as a plastic surgeon. I don't
Yeah.
know whether this goes with or doesn't go with what for you, what is the best thing about being a plastic surgeon?
I think it goes along with what the lady said, just kind of restoring patients' confidence in themselves. They've been living with some insecurity for a while, um, whether it be, the the loose tummy after having a kid, or maybe their breast changed after having a kid, or maybe their breast changed just as we get older, our skin changes, right? Gravity takes effect. We cannot combat gravity. So I think, just helping them with, their insecurities, and then seeing the confidence that, some people regain after having a surgery. It's an investment uh, that the patient has. So I want that investment to be worthwhile. So, restoring confidence, getting rid of some of their insecurities has always been, kind of a motivation for me. And, that's what I enjoy.
All right, Dr. Phillips. Well, we've learned a little bit about you and a little bit about your practice, just kind of scratched the surface, which is pretty fun, especially since it's been such a long time since I've seen your beautiful face. Um, So I want to hear a little bit more about if you had, we've talked about 8 volumes of plastic surgery and hand and breast and skin cancers of the face and all these different things. Do you have a favorite surgery?
I do. I like performing, just breast augmentation. Everybody
Cool,
looks at breast and they're never symmetrical. You can sit
right?
here if you measure everything down to the micromillimeter or nanometer or whatever they're called. You're going to find a difference, right? So you have to remember they're sisters, not twins. But breast augmentation, obviously you put the implant in and you see a difference right away. Um,
So you like kind of that one positive of breast augmentation is that it's an immediate result. You don't
right,
have to wait
right.
for some period of time or swelling or body. I mean, there are some things
Well,
like that. But well,
well,
tell us you see something immediate for sure.
right.
So
Yeah.
by all means, tell us a little bit more about the technique, how you like to do it, what you expect, what the process is.
Right. So yeah. So like you said, you see an immediate effect. Granted, it's not going to be the final result because the
Right.
implants do have to settle. So my approach is I do an inframammary crease incision. So that's an increase underneath the incision underneath the breast, usually about inch and a half to 2 inches long. So pretty small, right in that crease where that's going to be covered up by your bra or the bottom part of your breast. I typically do either dual plane, so partially release the breast tissue from on top of the muscle, and then always place the implants subpectorally or underneath the muscle. I always use silicone implants. I've never placed a saline implant. I don't plan on placing saline implants. And that's just because the durability of the implants, all the implants out there, to my knowledge, right now that are on the market that are silicone implants are gummy bear implants. There are different degrees of gummy bear implants, meaning the cohesiveness of the implant. So some are firmer than others, some are filled more than others, but all in all, they're all great implants. I don't worry about the safety of breast implants. Um,
Tell us a little bit about, you mentioned the cohesivity or that. What does that play out in the real world for the patient, the woman who's
um,
seeking breast augmentation?
I'm just
And
looking
what
here if I have a couple of implants here. I didn't know if I had different cohesiveness, but I don't. So
so when someone's deciding that, one, what do you use most often and why? And why would someone, the woman who has some knowledge of how this works, why would they choose one over the other?
right. So we use Mentor implants here at our practice. Um, Mentor has three different cohesivenesses. There's the memory gel implant, there's the extra, and then there's the boost. The boost is, to my knowledge, a little bit more cohesive, a little bit uh, more tightly filled within the shell. And how that relates to outcomes is they hold the boost implants, the more cohesive implants, hold their shape a little bit better. You see a little bit less of the rippling if you're going to see rippling. It
Which
gives,
is
which is, underneath the skin. The skin will kind of like do a little, maybe little undulations
little
underneath the
little
skin.
up and down, kind of more in thin people, maybe.
Exactly, and that's what I
Yeah.
was gonna. That's what you were gonna. I was gonna get to that.
Sorry.
Was no,
stealing
it's
your
fine.
th-
No, it's
stealing
good.
your thunder.
Well,
Sorry
could you
about
said,
that.
somebody
Uh,
that's knowledgeable about it, why would they choose one over the other? Um, but anyway, um, so I start out with just the Mentor Memory Gel for patients that have a lot of soft tissue coverage or a lot of breast tissue, where I'm not worried about the rippling because it's going to be under the muscle. So it's under the breast tissue and under the muscle. So I'm not really worried about seeing a lot of rippling in patients with adequate amount of breast tissue. So, but in the thinner patients, and I'm talking like super thin, like very thin envelope, somebody that's maybe a long time smoker, a lot of sun damage from years of tanning when they were younger. Those are the ones that I would kind of say, hey, you may want to think about having these boost implants because I can't take away all the rippling. But I know you're going to have less rippling if you use the boost implants rather than the the memory gel implants. So those are the patients that I kind of say, hey, go this way. They're kind of like the Ferrari of implants, right? Because however, as you get higher in the cohesiveness of the implants, price increases. So you have to trade off the risk, not the risk, but the benefit to the cost benefit ratio in that.
Absolutely. And so what you're really, I mean, in terms of rippling, you mentioned that one problem. You basically two things you're doing to, if I understand you correctly, to avoid that. One is you're using a submuscular implant, so you have the pec muscle on top as you raise
Right.
that breast tissue up. And then the second part is you're just basically watching how thick is the tissue, or how much fat do they have above, or breast tissue above there to kind of hide the implant? Because that's what every
Right.
woman wants, right? They may want more fullness, but at the end of the day, they really want their body to hide the fact that their breast is raised up by the implant. Is
Right.
that correct?
Yes. Yeah. I mean, I
Okay.
think, years ago, women wanted the Baywatch breast, these giant breasts with, I have a breast augmentation.
Mm-hmm.
And that's what a lot of women wanted. Some women still want that, but we're seeing more and more of a shift to, I want more natural results. I want to be
Mm-hmm.
fuller, but I still want to be natural.
I hear that a
So
lot. It
yeah,
seems like a trend, doesn't it?
yeah, yeah.
Yeah,
So I
absolutely.
think when you and I were in residency in Tennessee, we were probably putting on an average implant that we would put in was probably in the 500 range. I think that's
Probably
come
so.
down. I think that's come down a lot, to
Mm-hmm.
maybe 350, 400, which,
Yeah.
it doesn't seem like a lot on paper, but if you think about 150 cc's is roughly a cup size, we're instead of putting those double D's in, it's going to be that full C kind of cup.
Okay. You mentioned a technical term a little bit ago that I'd like to touch on slightly, and that kind of speaks to the also the submuscular or subglandular, another technical term. You mentioned dual plane. Tell people a little bit about the rationale for dual plane, what you're getting out of it, and why you kind of like that. What do you like about that pocket or that placement location
Right.
for the implant under the breast?
So I think for me, a lot of our patients have a very short uh, distance between their nipple and their crease. So the bottom of their
Okay.
breast is kind of short, kind of constricted, by doing a dual plane. So what you do, you dissect down to the pectoralis muscle, and then you make a little plane, or you divide the breast tissue off the muscle. So the muscle, so the the breast tissue can like slide up and release off of that crease, and then you cut the muscle, and then everything. So this is your breast tissue, this is your muscle here, rather than just lifting up the muscle and putting the implant in here, you kind of release this. And then when you release this muscle, it also goes up. So everything kind of elevates just the way, because it's still attached, you know, cephalad or superiorly. So everything kind of elevates up. So it kind of relaxes that a little bit. Sometimes it gives it a little bit of that, the lift look without doing, a full mastopexy. Um,
So you kind of get a little bit of a lift out of that dual plane without
right,
actually putting any scars on the breast, more or
right,
less.
yeah, and we're talking millimeters here. If your nipple position is below your crease or pointing downwards,
Sure.
that's not gonna work, right? If
Dual
the
plane's not going to fix that,
fill
huh?
plan is not gonna fix that. So, but in the right patients, you can in the right patients, I've been able to get somebody that I'm like, man, you're kind of right on the fence if you need an implant, if you need a lift or not. So if you go in understanding, hey, I'm gonna try it, and I'll put it subglandularly sometimes, so on top of the
Hmm.
muscle, to try to help, get a little lift. And I would say 99% of the patients that you do that in are happy.
Yeah.
They're like, man, I
Yeah.
don't want that scar around the areola. I don't want that up and
Sure.
down. I don't want that up and down. I don't want that anchor scar. I don't want that lollipop scar. I don't want that anchor scar on my breast. Um, but I know it's a chance that, I'm not going to be happy with this. So
Hmm.
I tell them up front, I'm like, hey, look, I know what your expectations are. As long as we're reasonable here, then if we put it in, and in 6 months you're not happy with it, we can go back and do a mastopexy later. I mean, a lot of surgeons, I think, still
Right.
do. They still do staged mastopexies. So they either put the implant in, wait 6 months, and then do the lift, or do the lift and then 6 months in, let her and then do the lift, and then 6 months in, put the implant in after that. So I don't like staging them unless you have to, unless you're just doing this of just tremendous lift. But yeah, so sometimes the art of plastic surgery, you have to be psychiatrist too. You have to like be like,
That's
hey, hey,
so true.
like let's like calm the expectations here, let's have some reasonable expectations. And I like to uh I like to do what I say is under promise and over deliver, right?
Right.
So set the expectations where you really think they're going to be. But I'm going to try my damnedest to, if this is my expectations and we set that here, I'm going to try to get you to here, right?
Right.
But sometimes no matter what I do, it's it's not going to hit, that dream body. I can't change your structural being, right? I can't change your bone
Right.
structure. So,
Yeah, well, that's important. So aside from the obvious, right, that the woman who has seeks breast augmentation has fuller breasts, what do you find in practice in terms of feedback? What do you see? What are they telling you in terms of benefit from that? What do your patients say in terms of the rationale for why they did it and why they're happy they did it? Because let's be honest, breast augmentation patients are generally very happy with what they decided to do. So where does that satisfaction come from aside from just the obvious breasts are bigger?
I think that maybe their clothes fit better.
Okay.
Maybe when, they look in the mirror, they feel sexy because again, kind of going back to social media, you see these, beautiful women and we're just talking about women here, because there's men models too, right? Um, they see, it's kind of forced down people's heads that the normal beauty is somebody that's thin with larger breasts. And so I don't know. I think it's kind of a mindset thing. So I think a lot of it is, kind of self-confidence. They
Sure.
fit their clothes fit better. Their their partner thinks that they're more attractive. That they feel themselves they're more attractive. So I think a lot of it really boils down to taking those insecurities away, and just kind of, you know, feeling better about themselves.
Yeah, absolutely. I feel like patients will have, and I think this goes along with what you're saying, that they can go shopping for whatever, blouses, t-shirts, bras, swimsuits, whatever, and just go pick something out and it works.
Right,
Like that they don't feel like they're shopping in the wrong, they need to go shop in the boys section or whatever else to find the clothes that are going to fit right, but they just pick something out and the
right,
clothes work, right?
right. Yep, yep, yep.
Absolutely. Anything else that you would say in terms of are there people that, this surgery is not a good fit for, or are there special risks that people should know about? It's certainly a procedure that gets a lot of attention and a lot of bad
Right.
publicity now. What would you say in terms of that, in terms of, who's the right patient for this? Is this really a safe procedure? And of course, we use safety as a relative term, right? There's no, just like in life, there is no certainty in medicine. People know that. People understand that surgery is not risk free. But in terms of being an acceptably safe procedure for people to do, is that the case? What do you? I would assume you wouldn't do it if it weren't. So what's the case for all that in light of all
So,
this media hype and
right.
negativity sometimes that surrounds this procedure?
So I think the right patient is someone that's healthy. If you have high blood pressure, it's controlled. If you're diabetic, it's controlled. So manage everything prior to having your surgery, obviously.
Don't fix it
Non-smokers,
afterwards, right?
yeah,
Fix
don't
it
fix it
before.
afterwards. Because I mean, unfortunately, we've had to cancel cases the day of surgery because their blood pressure wasn't controlled. I
Yeah.
mean, they come
Say
in and their blood pressure is 190 over 140. Well, we put you to sleep. Something bad's going to happen. Or something bad could happen, right? Like,
sometimes people don't remember that plastic surgeons are doctors first, right? So our
we are
knowledge, we
doctors
went we,
first. Yeah.
we went through medical school. In your
Yeah.
case and mine, we went through
Yeah.
general surgery as well.
And,
And at the end of the day, none of it matters if you're not safe, right?
right. Yeah. I mean, like you said, breast augmentation is a short and on the scheme of things with what we do, a simple surgery. But there's always risks. We want a breast augmentation to go as smoothly as possible, have as minimize the complications afterwards. So how do you do that? You prepare. So you prepare the patient's, blood pressure. We've put patients here on, antihypertensives and then have them follow up with their general practitioner to manage it. Here we always we order a mammogram for all of our breast patients. It doesn't matter if you're, 22 years old or 52 years old. Doesn't matter. If you haven't had a mammogram within the last year, we get one. Uh, we get some pushback from the radiology group sometimes that this patient's 24 years old, they don't need a mammogram. All right, well then do an ultrasound. We're going to get some imaging because about once a year we pick up a breast cancer. And,
Yeah.
and granted, it's an early breast cancer, But hey, in that one person, it
It's worth it, right?
yeah, and that one person, it's worth it. You know, we made a difference in that person's life, right?
Yeah,
And rather than needing a mastectomy, hey, maybe they could just get a lumpectomy
right.
or whatever it is. So hey, it's all about safety. Um, don't smoke. Smoking kills wounds. That's what I tell patients. Like wounds don't heal when you're smoking. They get infected. They open up. You want things to go smoothly, right? You want to have your surgery, you want to have your follow-ups, and then you want to be done with it. You don't want to have surgery, have a wound infection. Then you got to come in here once a week for us to look at you and kind of do this, and it's this long drawn out process. You don't want to do that. You want to have things go as smoothly as possible. So let's control as much as we can. Infections still happen. You can't prevent everything, but you can try to minimize it.
Right.
What else? A good diet afterwards, increase the protein. Because, like a tummy tuck incision, it's a big long incision. Big long incisions need a lot of calories to heal. So, keep up with your protein intake. Just basically try to do everything to minimize anything that could go wrong. Every doctor, I'm sure I have different, post-operative routines than you do. There's a
Right.
reason we've done this. We adjust. If we do something for a year and it's not working, or if it's like, hey, I talked to somebody and they had really good outcomes with this, we can try that. We're always evolving. But whatever your surgeon has landed on, they're comfortable with it. There's a reason they're recommending it. Follow your
Hmm.
doctor's recommendations. I mean, we have patients, on social media, on TikTok, like, hey, my doctor told me this, this, and this. What do you think? Well, I think your doctor knows you better than I do. So follow their recommendations, right? You
Right.
know,
Yeah.
so
It's like it's like a recipe, you know what I mean? And sometimes it's interesting to read someone else's article in the journal or to talk to another surgeon. And the decision about how they do something or manage it either during surgery or after surgery is part of a recipe. And so if you change that, what kind of downstream effects does that have? So that's why
right,
so many surgeons will use that line, right? Like in my hands, right? I'm sure you've said
right.
that. You probably said that on
Yeah.
this podcast, right? Is
I know.
in my hands this is what works. And I think
Right,
patients sometimes don't understand that, is that it's not a it's not the nuances of how we do things differently are all in the context of how we do the rest of what we do. So I
right.
totally agree with you. If
Yeah,
follow your doctor's instructions, right? Like don't
yeah,
do my
exactly.
protocol, do your doctor's protocol. That
Yeah,
will turn out best. And there's going to be
yeah,
so many similarities to what they do, right? I can't
yeah.
tolerate smoking either. It causes too many problems, you know.
It
And I don't
does.
even
Yeah,
no judgment against smokers. Like people enjoy smoking. I understand that.
right,
I just can't have it with surgery. So, and
right.
that was not an endorsement for smoking. No one take that out
Yeah,
of context, please.
yeah, yeah.
Yeah,
I had in general surgery, I had a attending once say, they were talking about techniques of the surgery. And it was like, if there's more than two techniques to do something, none of them are the best. But it's whatever your surgeon is experienced with, whatever your surgeon is comfortable with, that's going to be the best for you.
absolutely.
Because if you try to make a surgeon do something completely different, if you try to make a surgeon operate, using three fingers instead of four, like it's going to feel foreign to them. You're not going to get the best experience.
Yep.
So let the surgeon do what they're comfortable doing. I guarantee that's going to be the best outcome.
Okay. Yeah, I totally agree with that. Sometimes patients really want to have, or especially VIP patients, people that you know, or people that are nurses or doctors who are coming to get care. They're like, "Well, I want you to do it this way," and you kind of want to be like,
Right.
"Well, you should probably do it the same way everyone else does, so your care doesn't get messed up."
Right.
Right?
I mean, so
We're used to our routines on purpose.
there was a patient we saw in consultation the other day. What are you in for? Breast augmentation. Okay. First, so the questions I ask them are like, are you happy with the shape of your breast? So I'm gauging, do you need a lift or not?
Right.
Before they even undress, are you happy with your shape of your breast? Yes. Okay. Do you feel your breasts are different size? She said yes. Okay. Well, I'm thinking, okay, well, we may have to use different size implants here. Well, have you breastfed? Blah, blah, blah. Go down the whole thing. All right, fine. All right. Well, let me take a look. So I take a look, and it's obvious that one side is bigger than the other. It's like, and to the point where you're going to need different size implants. So I said, okay, so I'm do my measurements and do this. And I say, okay, well, in order to get you to a D cup, I recommend a, whatever size it was. Let's say 500 on the smaller side and a 425 on the larger on the
Sure.
larger side to even them out, right? She goes, no, I want the same size implants. So I'm thinking to myself, all right, you just told me one of the things that bothers you is your asymmetry, one side bigger than the other, but you want the same size implants. You understand that if I put the same size implants in you, their asymmetry is still going to be there. We're adding the same amount to both sides. Well, yeah, but I don't like the asymmetry. Okay, so that's why I recommended different size implants to try to even it out. I can't promise you they're going to be even. They're going to be, they should be closer than what they are now, but I can't promise you they're going to be even. Well, why not? And she goes, well, I just don't think we're on the same page. So I'm like, all right, you know, I will order 3 implants. I will order 2 of the same size, and then the size the asymmetrical size. Okay, fine. So she leaves, and then every day for a week, she calls our coordinator. I just don't know about this. We're just not on the same page. I just don't know. All right, we'll come back in. Have another consultation with her. Go through the same exercise. She leaves. For the next week, she calls the coordinator, and the coordinator's on her phone for an hour talking to this lady, like every day. So
Hmm.
at some point, I just said, "Look, I don't think I can meet your expectations. Like, and you'll never. I don't think you'll ever regret not operating on a patient for a reason like that.
Right.
Because if you do what she wants and you put the same size implant in, and she ends up asymmetrical, she's not going to be happy. It's not addressing her underlying concern. If you put in different size implants and they're still not symmetrical, but they're closer, she's not going to be happy because you told me use different size implants was going to address the asymmetry problem. No, I didn't say that. Like I said, they're going to get me closer. So, to manage these expectations again, it goes back to, just have that open conversation. And, so I think, yeah, did I lose a surgery? Yeah, I did. But I saved a lot of headache down the road, I think. So it's
Yeah.
kind of one of
Yeah.
those, give or take situations. Like just because there's food doesn't mean you have to eat it.
Yeah. Well, I feel like we're on the same page in terms of this, in terms I give the patients the line, when in doubt, don't. If I have a patient
Yeah.
who has serious doubts or they're really not feeling, I'm like, you
Right.
know what? This is probably not going to be a good fit for you. And sometimes they'll come back around and they'll have thought about it, ruminated on it 6 months, a year later, and it's time to do it. And I have done that. And then, you've been like, probably it still wasn't a good fit.
Right.
And then other
Yeah.
times they come around and they're happy. So
Yeah.
it all depends. It all depends on the patient. But like I said, I've heard a wise professor once say, if you can't envision having dinner with your patient, like casually, like just eating with them, if that totally sounds like something that you would never do, maybe they're not a good fit surgically. You know
Right.
what I mean? But
Yeah.
thankfully, we
And I
both
think
can
a
get
lot
along
of
with a
that,
wide variety of people. So
right. And I think a lot of that is just the maturation of a surgeon. When you're first out of residency, man, you want to hit that door running. You want to do everything you can, and you want to make everybody happy. After a while, you have to realize you realize I'm not gonna make everybody happy. So, at first I would promise the star, right? I'd promise that, man, we're gonna make you a model. I wouldn't say it. Obviously, I'm exaggerating here, but you're gonna be a model. But now, man, I see somebody with, obviously asymmetrical breast. They're different shapes, different sizes. I have to do one operation on one breast and another on the other breast. I'm like, look, I will tell you, you have difficult breast. You have difficult breast. I'm going to get them close. I'm going to do the best that I can do, but I can promise they're not going to be symmetrical. They're going to be close. They're going to be sisters. They're not going to be twins. And a lot of times, if you tell them upfront about that, they're happy. Like they're like, hey, I'm not expecting a miracle. Like I don't want perfection. I want improvement. And,
Yeah.
I would say the majority of the patients, if you're upfront with them and you say, look, man, you have difficult breasts, like these are tough breasts. This is a challenging case. And they understand that. They know that their breasts aren't the idolized breasts of the world, right? So, but they understand that, but they just want, like I said, they're insecure about it. They want to feel better. And, we can get them to feel better about themselves as long as the expectations are realistic.
All right. You got any stories for us, Paul?
So, one of the things on there was a funny story or a happy story. So I remember, I know we were doing
Who, we,
a
you and me?
me, you and Waldrop and, whoever else
All
was in
right.
the room.
Sounds
But,
good.
typically those micro cases, we're all in there, right? Because we get,
Yeah.
at the time we were doing maybe one a year. So you needed it for your plastic surgery numbers, whatever. Um, so, and I don't know if I was post call or, just up all night or I don't know, whatever. So I drank a monster that morning. Well, if you drink a monster a little fast, your hands might be a little shaky.
That's true.
But operating underneath the microscope, it's amplified, right? So, you move like this and it looks like you move like that on the screen. Well,
Yeah, little
sometimes,
shake is big shake
yeah,
on under
yeah.
the microscope, isn't it?
Yeah, and sometimes Dr. Waldrop had a little shake to himself, right? And he knew that. Awesome technical doctor, but sometimes he had a little shake to him. So, I'm sitting there, he's holding something and I'm under the microscope, we're sewing, and he goes, man, you're awfully shaky today, Paul. And I'm like, I'm just trying to get in your rhythm, Dr. Waldrop. I'm just trying to get in your rhythm, trying to match his shake. So,
Yeah.
yeah, that's kind of something that was funny to me. Um, Something else was this kid was in a car wreck and he came to our plastic surgery clinic and he's like, he had an orbital fracture, so a fracture
Okay.
for around one of the bones around the eye. So we're looking at him, doing this, and he goes, man, my eye just hurts. And he had been probably car week, a week out, I don't remember. He's like, man, my eye just hurts. Like every time I blink, it just scratches, it hurts, it itches. Like it's just, I don't know what's going on. I'm like, well, have you seen the eye doctor? Like, I'm not an eye doctor. Like, we can deal with the bones around the eye, but like the eye itself, man, I don't know. He goes, no, man, just look, doc, just look. So, I get his eyelid and kind of pull it back like this. I don't see anything. It looks okay to me. I get his lower eyelid, pull it down like that, and there's something in the corner of his eye, like between his eyelid and his eyeball. And I'm like, what is that? And I kind of look at it and pull a little bit more. And I'm like, hey, I'm gonna go get some tweezers, some forceps. And I pull it out, and it's a chunk of glass that
Whoa.
was like it was dime size. I'm not kidding you. It was a dime size chunk of glass, and I'm like, okay, I've never seen that before.
I
And he
bet
was
you feel
like,
better now.
oh my God, it's gone. I'm like, dude, like, have you not looked in the mirror, like, to look and see if there's anything in your eye? Like, I mean, I know how irritating an eyelash can be. I can't imagine a chunk of glass in your eye. But, so it's just like the things that we can see sometimes is just like, wow, like
You saved his
unbelievable.
life.
I, I saved his eyesight, maybe. I don't know. I saved him from going insane for having something, poking his eyeball. But,
Uh-huh.
and that's something people are like, you know, plastic surgery, you're not really a doctor or whatever, you're not saving
Yeah,
lives. You're absolutely right. I didn't sign up for that. I don't want to save anybody's life, right? I did that in general surgery. We went through five
true.
years of we went through 5 years of trauma. Like trauma surgery is 98% boredom and 2% chaos. But I want to avoid the chaos now. So but no, I
Hmm.
mean that's just kind of funny things. Like I'm sure there are more stories in the back of my head that I've either repressed or done whatever, just because of the world gets in the way sometimes.
Absolutely. But yeah, I mean, it's interesting how, yeah, the life saving, that's not really something that we do so much anymore,
Right?
but we
Yeah.
are in the business of restoring and
Yeah.
helping and rejuvenating and making
Right.
lives better, aren't we?
Yeah. 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 So just kind of thinking about saving lives, right? So right before COVID hit, my wife and we had traveled to Las Vegas with some friends, and one night we were out And one of our friends had way too much to drink. I mean, way too much. And we were outside, we were waiting on the Uber to take us back to the hotel. And the guy that we were with, he just, passes out, just flat falls down, face first into the concrete. So his
Oh,
nose, I mean, yeah. So, I mean, and his nose is obviously broken. Like, you don't need a CT scan for this one, right? I mean, it looks like, you
ah,
remember the Home Alone scene when the robbers are going into the house and the guy, I think it was Joe Pesci, gets hit in the face with the something and his nose is, pointing like that. Like, that's what this guy's
uh-huh.
nose looked like, right?
Yes.
And all of our friends are like, "Oh, you're a plastic surgeon. You fix it, fix it." I'm like, like, we're in Vegas. It's 2, 3 in the morning here. Like, well, what do you want me to do? Like, I'm like, here, get bench right here. Like, I'm like, I'm not touching you. Like, you got blood on everywhere. Like. So it's just like, yeah. I mean, normally you could fix this in a controlled setting, but out here waiting on the Uber, like, just get some paper towels, man. Like, that's all you can do.
Stop,
So
stop the bleeding, right?
yeah, just stop the bleeding, man. It's just like they're like, why don't you do anything? Because there's nothing to do at this time. There is nothing to do, So
Yeah. Well, stopping the bleeding's big, right?
yeah, I mean, all bleeding
That's
stops eventually.
that's a classic surgical saying, isn't it?
Yeah, yeah.
Yeah. Well, do you have any additional advice for the would be plastic surgeon or the patient seeking plastic surgery? What are some pitfalls for, there's a lot of people out there who are kind of I don't know, are there people who are either national or international who are kind of doing what you do but aren't plastic surgeons, or is that just only something that happens when you go to the Dominican to have a little destination surgery, or what does the public need to be aware of when they're seeking out plastic surgery services?
Right. So, the medical tourism or, things like that, are there good surgeons? And so we're in San Antonio, we're a couple hours away from Mexico. So we have a lot of patients that go down to Mexico to have surgery. There's good surgeons in Mexico. There's bad surgeons in Mexico. There's good surgeons in the US. There's bad surgeons in the US. The difference to me is what happens if something does go wrong? Who's going to take care of you? If you're down in Mexico, you don't know what's going to happen. Like, the hospital quality down there is not the same as it here is in the US. So I would be very careful on where you go, not because of only the doctor that's going to be operating on you, but what if something happens? And some things take a while to happen. It may not happen within the first week that you're down there. So if you're down there and something happened, everything goes great when you're there, you go home, and then 3, 4 weeks later, something happens. Well, what's going to happen then? Who's going to take care of you then? Are you going to have to go back down to Mexico to, get this problem
Mm,
addressed? Or is somebody in your area going to take over for you? I know here, if we take over care from, another surgeon's office, then, the price can be pretty outrageous because it's something that, quote unquote, we didn't cause. But now we have to kind of play catch up to the game. And it's if everything looked great at a week, and then you started having an infection, and we take care of that. You're going to remember in your head what you looked like at 1 week. You're going to forget that you had an infection and that we had to take care of that. So then, if 6 months later your results aren't what you wanted, that's because we did something. Because you remembered that 1 week appearance. So then all of a sudden, that's our fault in the patient's mind, even though we may have just treated the infection and what natural course changed whatever it changed.
mm,
So that's what I would you know caution people on is what happens after the fact. You know, as far as who's going to take care of you afterwards, who's going to manage whatever issues might arise down the road.
So
Um,
the savings that you might have from traveling, doing some medical tourism, traveling
right,
internationally, might not be worth it.
right. Are there good surgeons everywhere in the world? Yes, but are there surgeons that are going to take care of you afterwards, yes.
All right. Any plastic surgery jokes or anything else?
Man,
Funny?
I was trying to think of one. I'm like full of dad jokes, but none
You
of
got
them
a
are
couple.
funny. None of them
All
are
right.
funny. I can't remember. Uh,
I'm not a joke person either, so that's fair.
I mean, my kids, as soon as I say, "Hey, I got a joke for you," they're just like, "Oh God, here we go again."
Run to the other room,
So
huh?
I've retired from joke telling, I think.
All right.
Um, One of the things that here on your closing thoughts, it says trends I'm watching in plastic surgery. One of the things that I'm very interested to find out about down the road are the these weight loss shots. What's going to happen to these patients that are on the Ozempic, the semaglutide, whatever you want to, Manjaro, whatever formulation that is out. Yeah, you lose weight. What happens after you stop taking that shot? Do you go back to overeating, not exercising? Does your weight go back um, to what it was, or what? Or while you are at the low weight and we do your tummy tuck, do you have enough protein caloric needs to offset the healing problem, or the offset the healing needs that's required? So that the long-term effects of these, are they good drugs? Yes. They're great drugs for what they're supposed to do. But the long-term effects, like with anything, they're kind of yet to be seen. So it's going to
Yeah.
be interesting, I think, is, how these drugs continue to evolve. And then what's the next step? I mean, when you and I were in general and plastic surgery, bariatric surgery was a big thing, and it still is. But now people are like, oh man, I can get the same results by taking a shot. I don't want to have surgery. I'm going to take the
Right.
shot. So, it's going to be, this evolution of medicine and how everything changes. It's always, what's next, what's next, what's next, and what are the consequences and what are the lasting effects of whatever. So that's going to be very interesting to see.
What do you think history would tell us about scientific history, I guess, about when the people stop taking the shots, what will happen?
I think you're going to revert to, unless you really make a personal, behavioral modification, you're going to regain that weight. I mean,
Yeah.
if you diet and exercise, well, you lose weight, but then you stop your diet and you stop your exercise, you go right back to where you were,
That
you
seems to
know?
be how everything works, except for
Eh,
surgery, which is a
Right. Yeah.
permanent change.
But
Yeah.
even then, these
Even
gastric
then,
sleeves, even then these gastric sleeves and to some degree gastric bypasses, you can eat your way through it. I mean,
true, true.
so, I mean, it's all about behavior modification. It takes what, 30, 60 days, something of doing something consistently to create a new pattern in your
Make a habit.
psyche, and yeah, to create new neural pathways, as people say, and start thinking about things differently, start acting differently. It takes 30 to 60 days for things to change, to become, the new norm.
If you enjoyed today's conversation, be sure to subscribe so you never miss an episode. You can learn more about my practice, explore additional educational resources, and find all of our podcast episodes at calebsteffenmd.com. You can also follow along on social media at calebsteffenmd for surgical education, behind-the-scenes content, and updates on future episodes. If you found value in today's discussion, we'd be grateful if you left a rating and review on your favorite podcast platform. Your support helps us reach more surgeons, trainees, and anyone interested in the field of plastic surgery. Information shared on this podcast is intended for educational and informational purposes only. It should not be considered medical advice and is not a substitute for consultation with a qualified healthcare professional. The opinions expressed by guests are their own and do not necessarily reflect those of Dr. Caleb Steffen or this podcast. If you have questions about your own health or medical care, please consult your physician. See you next time.